Very much for this very kind introduction. First of all, I would like to thank the organizers for this invitation. This is my first time in Sorrento, and a special thanks to Carlo. And actually a special thanks to the whole Poseidon groups who has given us a clinical tool to work with, because first and foremost, I'm a clinician and we like working in strategies. And I think the Poseidon criteria have allowed us to do that. So the topic of my talk today is to talk about the LH in patients of advanced reproductive age. So these are my disclosures. And what are the learning objectives? We're going to just reiterate, because at this Congress we've heard a lot about the importance of the role and the importance of the LH in the folliculogenesis. I'm going to try to explain the effect of ovarian aging on gonadotropins, and of course to show the importance of the choice of gonadotropin in ovarian stimulation in this difficult patient population. So let's start from the beginning. What we do in ovarian stimulation, we actually only interact in the last 10 to 12 days of the folliculogenesis. So we know that this sensitivity is mostly influenced by age. And having a better understanding of the physiological process can help us understand and improve ovarian stimulation. And you've seen different variants of this slide, but we have to understand how complicated the interplay is between the main roles and the main key leaders in this process. So the basal level of LH and androgens is crucial in the expression of the FSH receptor. And this is how the follicle gains the sensitivity to FSH. In turn, the estrogens, which are produced by conversion of androgen, are crucial in the expression of the LH receptors. And this is how, in the granulosa cells, and this is how the follicle gains its sensitivity to gonadotropins. So there is no successful folliculogenesis without the FSH and the LH, of course. And I've been in IVF for many, many years, and it's actually interesting. In the first days, in the beginnings of IVF, we did a lot of empirical stuff. And now, after so many years, what are we doing? We're actually coming back to nature. And the action of FSH and LH is determined by many things. You all know that. The frequency of the pulses, the different isoforms, you've heard from other presenters, the polymorphisms. Christos very elegantly talked about that. And I'm going to concentrate mostly on the aging. And we all know in everyday clinical practice that our patients are getting older and older. And this is actually the ARA data, the last data published in 2023 on the results of ART in 2019. And we have increasing proportion of patients of advanced maternal reproductive age. And I'm going to focus mostly, actually only on the patients 35 to 39. Why? In the first lecture today, Alessandro showed you enough data to explain that in the patients who are older than 40 years, we cannot account or we cannot influence the outcome because we're really faced with the age problem. So I will focus on the patients who are 35 to 39 years of age. And then let's talk clinically. Why are these patients so difficult to treat? So what is the ovarian aging? First and foremost, we know this. It's a decline in ovarian reserve, the lower MH and FSH. We have a decrease in the oocyte quality. It's the euploid rate. We have, of course, progressive increase in the FSH levels. But what is very, very important, and maybe we don't pay attention to it so much, is the decrease in the bioactivity of FSH and LH. And what does this mean in practice? So the decline in the presence of partially glycosylated FSH variants, which have greater affinity for the FSH receptor than the fully glycosylated FSH glycoforms. And then also regarding the LH isoforms, they change to much less active forms with aging. And then the decreased LH bioactivity impairs androgen production. And we have just seen from the previous slide how important is both the LH and the androgen for the acquisition of the FSH receptors and the sensitivity of the follicle to the FSH stimulation. And then in turn, this reduced action of circulating gonadotropins caused by aging results in reduced steroidogenesis and decreased ovarian function. So just to focus on the LH, we have, as we said, less functional receptors, we have lower potency, we have a drop in androgens. So there is a rationale to use LH in the advanced reproductive age. And let's talk about the effect of aging on oocyte and embryo. And the first thing that comes to mind is the euploidy. But it's not only the effect on the oocyte and the euploid rates. We have to think of the embryo viability and competence. Why? Because we know that the aneuploid embryos also implant. So aging is not only about the reduced euploid rate. And we know that the aging creates this instability in the division machinery which is present in these older women and caused by the prolonged arrest of oocytes at the prophase of meiosis 1. So you have the disrupted meiotic spindle, you have the increased rate of meiotic error, and you have arrested M2. And also you have the impact of age on the cytoplasmic maturation. And there you have what I was talking about, the problem with the competence of the embryo and its viability. But then if we ask the question, can we counteract the ovarian aging with specific exogenous gonadotropins? FSH and LH promote granulosa cell activity and survival. And actually, this is the anti-apoptotic effect of LH that we have been hearing about so much, because LH can activate the pathways which are anti-apoptotic. And this is crucial in deciding how many granulosa cells survive in the last stages of oocyte maturation. So what does this actually mean? In the last stages of the follicular phase, you have a huge increase in both the oocyte size and the oocyte volume. And this is the moment where the capability of the oocyte is reached and where it regulates actually the embryo viability. And this is the moment where LH is crucial for regulating both the oocyte and embryo competence, which is completely independent of the meiosis and the euploid phenomena. I like coming back to this. You've heard, of course, a lot about Poseidon. And as I said, we clinicians like to work in strategies. And what is different about Poseidon to Bologna, Bologna just looked at ovarian response, so the ovarian reserve and the number of oocytes. And Poseidon introduced the concept of low prognosis. We have the quality, which is seen by the ovarian sensitivity, and also it takes into account the age-related euploidy rates. And again, you have seen this slide many times. I will skip over it. And you've heard today also from Christos about the FORT and FOI. And why is it important? I will come back to it in a minute, where I talk about the unexpected response. And as Christos said today, it's a very frustrating condition when you have had a number of good follicles, but you end up, a number of good follicles to begin the stimulation with, but you end up with only few eggs. And to show it biologically, it's the Poseidon group 1 and 2 who have low FORT and FOI. In other words, you have not used the potential of the ovaries. And in the Poseidon groups 3 and 4, they will have high FORT and FOI because you've stimulated everything that there is to be stimulated. And in the end, you have the same number of oocytes, but a completely different prognosis for these patients. To explain when do we need to give LH, I come to this slide talking about the relevance of LH in the follicular phase. And we all know that the LH receptors are expressed in theca and granulosa cells. And in the follicles, which are 5 to 10 millimeters in diameter, you have LH receptors in up to 80% of the follicles. And these are the follicles we begin the stimulation with. And of course, as the follicles grow more than 10 millimeters, the expression of LH receptor increases. So if I'm asking you as a clinician, when should we start with LH? I think the answer is pretty straightforward. You start from the beginning of stimulation. And in fact, this is a study published some time ago, which looked, it's actually the agonist protocol, but they looked at group A, which had recombinant FSH and LH from day 1 in ratio 2 to 1, and the group B when it was started from day 6. And the group who had LH from the beginning of stimulation did much better, which is quite logical. So in patients of advanced maternal age or reproductive age, you should start with LH from day 1. And this is the unexpected hyper-response situation, where I think we have seen this study in different forms, where it's also a long agonist protocol, but after 5 days stimulations, the patients were randomized either to increase, the patients were started on recombinant FSH, and they were randomized either to increase the dose, to add LH. And as expected, the patients who had the recombinant LH added did much better. So to answer the question, when should you start with LH? If you have an unexpected response after the first few days of stimulation, unexpected hyper-response, there is place for you to give LH from day 6. But when we're talking about the patients of advanced maternal age or reproductive age, you should start from day 1 of stimulation. So what can we expect from different gonadotropins? Can we influence the ovarian reserve? Of course we can't. Can we influence the age-related euploidy? We can't. Can we influence the ovarian sensitivity and the oocyte embryo competence and viability? We can try, or yes, we can. And how do we know that we're using the optimal treatment? To answer the questions, what are the real-world outcomes for low prognosis? Actually, Sandro published the first study a few years back, where he looked at the cumulative delivery rate per aspiration in patients aged 22 to 42. So they used all the fresh and frozen embryos until live birth was reached. And even if you don't know anything about this, when you look at the slide, when you look at the pink part, that's the patients who are younger than 35 years compared to the blue part. They are the patients who are older than 35 years. And the first column are non-Poseidon patients. And the other columns are Poseidon. So the pink is Poseidon 1 and 2 and 3, and the blue is Poseidon 2 and 4. And you can see how worse they do in relation to normal population. So this is the first study which proves the concept of low prognosis in the Poseidon patients. And to answer the question, is LH supplementation effective for advanced reproductive age? And to answer the question, do we have good evidence? This is in fact the meta-analysis published by Alessandro, and it examines the effect of adding the recombinant LH to patients 35 to 39 years. Unfortunately, the evidence which was used was not of very high quality. We have the issue of clinical heterogeneity and methodological variability, which is caused by different sizes, so different sample sizes. Also in some of the studies, LH was started day 1, in another day 6. But nevertheless, these are the results. And when you look at the number of oocytes, fewer oocytes were retrieved when recombinant LH was given in stimulation. But the number of mature oocytes was equal, and the patients who had recombinant LH, in addition to recombinant FSH, did much better. They had higher implantation rates and higher clinical pregnancy rates. And here we're again talking about the influence on quality. And what additional evidence we have? We all know that RCTs are the golden standards, and you will hear from Christos in the afternoon a little bit more in details about this. But we know that also RCTs are costly and time-consuming. And lately we have had the emergence of the real-world data. So the real-world data involves heterogeneous populations. These are observational studies, large data sets, and actually it gives us the insight on the RCT outcomes. What is important to be stated are that the RCTs and the real-world data are complementary. And this is the famous German registry study. And this is the first study which looked at the effectiveness of the recombinant FSH and LH in relation to recombinant FSH only for ovarian stimulation in patients of advanced maternal age. So the data set included almost 15,000 women. Of course, you have to take into account that these huge data sets have a lot of confounding factors. And then the propensity score was applied one-to-one to minimize this effect of the confounding factors. And it was ended with almost 4,000 patients in each group. And if you look at the results, similarly to the previous data I've shown you, the number of oocytes retrieved in patients who had recombinant FSH and LH was lower, but you had higher clinical pregnancy rate and higher live birth rate. And of course, you have to take into account that this is real-world data, so this is a non-interventional study, so there is no information on ovarian reserve. So what was taken as a surrogate marker was the number of oocytes. So patients who had 5 to 14 oocytes retrieved are considered the normal responders. And I will show you the data in a minute. But what I find very interesting as a clinician is that if you see, so these are the patients who had 5 to 14 oocytes. And look, these are your sort of very, very low responders. And what is the clinical thinking? These are the patients, so the worst outcome, I'm going to give them more recombinant LH. But if you look at the presumed high responders, the clinicians opt more just to give FSH. This is just an interesting finding which reflects, I'm sure, all of our clinical practices. And looking at the patients who had 5 to 14 oocytes retrieved, so the presumed normal responders, you can see that patients who had the recombinant LH did much better in the clinical, with a higher clinical pregnancy rate and also higher live birth rate. And this is actually the first study showing it in these numbers. So the combination, so the recombinant FSH and LH gave a 16% relative greater chance of clinical pregnancy and live birth versus recombinant FSH only in the advanced maternal or advanced reproductive age normal responders, so patients who had 5 to 14 oocytes retrieved. So what are the signals from this study? Is that the recombinant FSH and LH may help overcome the impact of aging and LH deficiency on the oocyte quality. And to answer the question, is actually the choice of gonadotropin important? This is the French database study looking at the first ovarian stimulation cycle in the 5-year period. The primary outcomes were the live birth rate and the cumulative live birth rate. Huge number of patients involved, 245,000 cycles and 150,000 patients. And what were the results? What is interesting is this is what the clinicians do in France. And you can see the first column, the pink one. These are your patients who had the recombinant FSH, the alpha and beta originator. So the first impulse to stimulate is to give the recombinant drug. The blue one is only the recombinant FSH originator alpha. So in other words, 2/3 of the prescribed gonadotropins in clinical practice are recombinants. And all these patients had, the groups had comparable demographic and treatment characteristics. You can see younger patients, Cumulative gonadotropin dose was higher. The purple one is the urinaries, the highest in the urinaries. And if you look at the treatment type by age, if you look at this graph, you can see that as the patient age, they're given more urinaries. In this case, it's the more of the LH activity. And if you look at the outcome, when you compare the recombinant FSH alpha originator via biosimilars, you have odds for live birth rate were lower with the biosimilars for 19% and with the cumulative live birth rate 14%. And the same thing is seen in the urinaries. The odds for the live birth rate were lower 7% and the cumulative live birth rate 11%. But what I found interesting is that this direction of effect is maintained regardless of the age and the strategy. And especially why it's interesting for me, because, okay, these are your poor prognosis patients, these are your older patients who are mostly treated with the urinaries, but the effect is the same. Even in this low prognosis patient population, the recombinants did better. And also, whenever we look at the data, whenever we discuss, we have to be very honest and talk about both the strengths and limitations. The good thing about this, it's a national database. The results are consistent with literature. Data is routinely collected, but the limitation is there is no ovarian reserve data. And as a clinician, I always like to see what is actually being done in clinical practice. And this is actually the Arabian Gulf Delphi Consensus Group, 35 or 36 experts grouped together, and they gave 36 statements. And they actually tried to answer which are the factors which influence the response to ovarian stimulation, which patients need the LH supplementation, and what are the strategies to do that. And in the statement 16, I'm just putting this for you because I found it interesting that this approach is particularly relevant for individuals who meet the Bologna criteria and those classified under the Poseidon framework. And it's a strong consensus. You know, we're all clinicians. We don't always think the same, but this group of experts reached almost a 90% consensus. So in other words, what we talk about in all these lectures is also transmitted in clinical practice. So to finish off my presentation, LH is a hormone which nature has selected to be part of the follicular phase. These LH receptors are present and expressed increasingly during the follicular phase. LH deficiency can be associated with both impaired production and action. And what is very important is the advanced maternal age impairs the LH production and actions. And hence, the strategies of ovarian stimulation are associated with LH deficiency and the need for LH treatment. So my final message is, whenever you leave a talk or a presentation, the question is, what are you going to do? Or I ask myself, what am I going to do in my clinical practice? And my message for you is, think about the right choice of gonadotropin for your patients, because one size does not fit all. Thank you very much.